Good evening, everyone. I welcome you all again in our next episode in series of these webinars on detailed discussion in diabetes, especially in Indian patients, that is 4D 2.0. So we have been talking about complications of diabetes like diabetic foot. Today we'll be talking about a complication that is one of the most difficult complications to take care of because not only the mortality that is increased in this complication, but also the morbidity also increases rapidly. We will be talking about chronic kidney disease and diabetes today. If we talk about the data, around 15 to 20% of our OPD patients have some sort of CKD, especially if we start using the definition of EGFR less than 60 ml per minute. Then many of our patients have this complication right at presentation or during the course of the disease. It is important to understand this complication because not only we need to treat the patient for chronic kidney disease, but we also need to change the medications according to the EGFR status of our patients. There are certain medications which we need to stop. There are certain medications which are specially indicated in this scenario. And for today's talk, we have a very special guest, Dr. Athia Khila. She's a highly qualified endocrinologist. She did her MBBS from Osmania Medical College and then her MD in internal medicine from Chalmeda Anand Rao Institute of Medical Sciences. Then she pursued her DM in endocrinology from Osmania Medical College. She is currently practicing at Nirmal Private Clinic and Nirmal Neuro Hospital, where her main focus is juvenile hypothyroidism and other endocrine disorders. She has extensive education and clinical experience in this field. Welcome, Dr. Akhila. We welcome you here on
Yeah,
this.
thank you.
For today's, we'll love to hear from you about diabetes and sleep.
Sure, sir. Thank you. Thank you for the warm welcome. So today I'm going to talk a few points regarding the most common, one of the most common complications of diabetes, that is like microvascular complication, that is kidney damage in diabetes. So I think shall I start with the discussion? So diabetes in India, as we can see, it's like most of the diabetic patients in our OPD, around 10% of the population in the OPD. When we look at the investigations and see the creatinine clearance, so most of the people will be having mild decrease in the GFR. When it comes with the longest duration of diabetes, the proportion of the population ending up in decreasing in the renal function will be more. So it is like most commonly related with the duration of diabetes and also the previous status of the diabetes in that population. In India, as we know that it is the most populous country, and we can see the number of people with diabetes is also like second highest in the world. So the proportion of the people, that is the adults living with diabetes, is more, that is around 1 in 11 are with diabetes in India. So over that, in that 50 percentage of the adults are undiagnosed because of lack of screening tests. So whatever might be the economical constraints and all to diagnose diabetes, so over 50 percentage are undiagnosed, and whatever the diagnosed, like around 1 in 11 are people with diabetes, they have landing up to into complications of diabetes, like one of the complication, diabetes with CKD. So we can see that the diabetes and CKD, what is the association? So here, factors contributing for the CKD in diabetes is, one is uncontrolled diabetes, that is like just the increased blood sugar, and the other 29 percentage of the CKD might be because of the high blood pressure associated with diabetes, which is uncontrolled, and multiple other factors which can be like the in situ glomerular disease or a polycystic disease, which is associated finding in the patients with diabetes. So what is the mechanism here? So as we know that the diabetes, the hyperglycemia, if it is not controlled, so one is like effect on the glomerulus and the other is on the proximal tubule and the hormonal mechanisms. So on the glomerulus, the hyperglycemia induces increase in the production of the angiotensinogen and thereby increased activation of the angiotensin converting enzyme, and finally the product angiotensin 2. So this angiotensin 2 will have an effect on the albuminuria, increases albuminuria. That is called hyperfiltration. That is by causing this angiotensin 2 is a vasoconstrictor. It constricts a efferent arteriole. So by that, the constriction of the efferent arteriole, intraglomerular pressure rises and thereby increases the filtration of the glomerulus, thereby causing albuminuria. And the other mechanisms is direct effect of this hyperglycemia on the proximal tubule increases the expressions of the SGLT2, thereby causing increased sodium reabsorption. So this increased sodium reabsorption will be causing single nephron EGFR will be increased. So thereby causing the hyperfiltration stage, again the albuminuria will be increased. And then the proximal tubule, the other effects like mRNA renin expression will be increased and thereby also causing increase in the angiotensin 2 and thereby once again efferent arterial vasoconstriction, same intraglomerular blood pressure will be rising. And all these put together contributes for the progressive CKD. So all put together, the CKD we know that it is progressive and irreversible loss of kidney function. So how can we diagnose it? Just labeling kidney damage. If it is chronic, we have to label after a duration of 3 months minimum with an EGFR of less than 60 ml per minute persistently. So how do we classify and screen the kidney damage in diabetic population? So we can classify based upon the glomerular filtration rate. So the staging is like it is more than 90 ml, it is normal glomerular filtration. So the first impairment of the glomerular filtration starts with like 60 to 90. It is like a grade to mildly decreased renal function, and then mildly decreased to moderately decreased is like a stage 3A, 45 to 59 ml per minute GFR, and it is like moderately to severe decreased, it is 30 to 44, and severely decreased renal function is like AGFR 15 to 29, and completely anuric phase, that is completely irreversible renal failure is less than 15 ml. So this is classification according to the glomerular filtration rate. So based on the stages, we can see that the albuminuria is also there based on the grading. So this albuminuria stage 1, it is like normal excretion that is less than 30 milligram per gram of creatinine. It is a first stage or it is normal. And it is like microalbuminuria, we label it as like albuminuria from 30 to 300 milligrams per gram of creatinine with microalbuminuria, and it is overt proteinuria if it is like more than 300 milligrams per gram of creatinine. So we know that the diabetes itself is also a risk factor for the kidney damage apart from the comorbid conditions like uncontrolled hypertension and all. So what are the modalities for the treatment of diabetes which can be targeted towards the kidney as well? So one thing is like strict control of the blood sugars that can be made by early initiation of the combination therapies. So we have today so many novel medical agents which can counteract diabetes as well as the glomerular injury to the kidney. So now the novel medication which we have is like SGLT2 inhibitors and DPP4 inhibitors and the GLP-1 receptor agonists. So pertaining to the kidney, actually SGLT2 inhibitors will have a specific role. We can see based on their advantages in the recent trials, and the outcomes of those trials are very much provocative to use these inhibitors in the early stage of kidney damage to prevent the progression. So this SGLT2 inhibitors will have the multiple effects which can aid in the avoiding the progression of the kidney damage. They can promote the weight loss, they can produce glucosuria, decreasing the glucotoxicity, and inhibit the glucose reabsorption, and decreases the blood pressure as well, systolic around 4 to 6 mm and diastolic around 1 to 2 mm, and even with lower risk of hypoglycemia. And the addition of other molecules like DPP4 or GLP-1 receptor agonists can aid in the reduction of the HbA1c, thereby decreasing the glucotoxicity of the on the kidneys. So DPP4 inhibitors, we can see that they can be like beta cell protective, and also inhibits the glucagon secretion from the alpha cells. And they are weight neutral, they avoid the weight gain, and with a significantly lower risk of hypoglycemia. So, all this put together, the combination will help sustain the glycemic control and counteracting the insulin resistance and improving the beta cell function and optimization of the body weight and reducing the pill burden, and overall cost effectiveness is also better. So, the most common molecule which we have today in day-to-day clinical practice comparing this SGTL2 inhibitor is the dapagliflozin. So it's like well tolerated with the sitagliptin combination, and we can see very significant reduction in the glycemic parameters after like 48 weeks of treatment. So we can see here the HbA1c reduction in the study week first graph. It is like showing almost like zero point 0.4 to 0.6 percent. I mean percentage of HbA1c reduction, and in the combination it is like almost like zero point 0.4 zero point 0.6 at the 48 week. So isolated use of the SGLT2 inhibitor has reduced the effect meanwhile in like after about 32 weeks, but the combination has led to the persistent maintenance of this HbA1c. So what are the advantages we can have with these SGLT2 molecules? So as we can see in the previous slide also, we noted that the glucotoxicity and the plasma volume is decreased because of this SGLT2 inhibitors. And finally, reducing the blood pressure, uric acid, and triglycerides, and decreasing the cardiovascular risk as well. And DPP4 inhibitors will have effect on the endothelial function, reducing the oxidative stress and counteracting the glucagon effect and improving the incretin effect, insulin secretion. So all these put together can help in the overall conservative management of diabetes and also overall management of diabetes, not only hyperglycemia. Coming to the studies which we have in our clinical practice, the dapagliflozin has underwent like many of the clinical trials like DAPA-CKD, DECLARE-TIMI, and DAPA heart failure studies. So all these studies have shown that significant decline in the progression of the EGFR, that is like at least 50 percentage in the decline in the progression of the CKD2 and stage renal disease or death from the renal outcomes. And it is in declared TIMI, we have it is shown that the composite of endpoints was like greater than 40 percentage decrease in the deterioration of GFR to less than 60 ml per minute. And in the DAPA heart failure, it has shown that significant decrease in the death from the renal causes as well as progression of the CKD to more than 50 percentage in the end stage kidney disease. So all these are brought about by the multiple pathophysiological mechanisms which are induced by the SGLT2 inhibition. So one is like direct effects on the kidney, that is like tubular glomerular feedback, thereby causing the constriction of the afferent arteriolar, thereby reducing the intraglomerular pressure, and consequently the glomerular hyperfiltration is decreased, thereby decreasing the albuminuria. And then the glucosuria and natriuresis will be having direct effects on the cardiac function, decreasing the plasma volume overload on the heart, and thereby decreasing the incidence of heart failure. And in the pancreas also, it has like increasing the glucagon and decreasing the improving the insulin sensitivity and improving the insulin secretion from the pancreas, and thereby decreasing the glucotoxicity. And most advantage is also because of the weight loss. And lipids, we have SGLT2 inhibition. We have noted that there is a induction of lipolysis within the body and increase in the uptake of the non-essential fatty acids and decreasing in the fat mass. In cardiovascular benefits, we have seen that the arterial stiffness is decreased, plasma volume is decreased, blood pressure is decreased, endothelial function is improved, and decreasing in the incidence of the heart failure. So this SGLT2 inhibitors, like evidence-based studies have shown that the dose adjustment is needed in the presence of CKD. So dapagliflozin, it is recommended 10 mg daily. Initiation of this SGLT2 molecules is not indicated if the GFR is less than 25 ml per minute per 1.73 meter square of the body surface area. This is because the SGLT2 molecules will not be excreted through the renal if it is severely compromised renal function, that is GFR less than 25. So the tubular mechanisms of SGLT2 inhibitors cannot be possible if they are not excreted into the tubule. So that is why there is no point in initiating the treatment if it is less than 25. And DPP4 molecules, like for example the sitagliptin, the maximum dose it is like 50 mg daily in presence of CKD, and if it is like less than 25, we can use it as like 25 mg once daily. As we know that the diabetes treatment, it's not like just the treat blood sugar and leave it off. It's like a holistic approach is needed to counteract the multiple effects of diabetes on various organs like hypertension or the damage to the kidneys, damage to the retina, damage to the nerves. So there are multiple effects which needs to be addressed when treating a patient with diabetes. And apart from that, we need to monitor what are the complications he is going into, and we need to check all those apart from treating his blood sugars. So we have to treat his lifestyle, we have to improve the diet, we have to increase the physical activity, we have to like smoking, alcohol intake has to be curtailed. We have to manage the weight of the patient and accordingly change the treatment of the diabetic based on his body weight. And depending on the risk factors or all the comorbid conditions, depending on this cardiac status, we may prefer either SGLT2 inhibitors or GLP-1 receptor agonists as well as the first line therapy if he is at a high risk patient. Then the second line molecules will be always like the metformin if it is like already high risk patient. If it is like less than without CKD and without any cardiac problems, then we may initiate with metformin and later on escalate the treatment with the other molecules like DPP4 inhibitors or the sulfonylurea molecules. So we need to monitor his blood sugars, we need to monitor his albuminuria, we need to check his lipid profile, we need to assess the risk assessment for this patient depending on his family history, depending on the number of cardiac events in the family or the family history of CKD in the previous generations. So depending on all the findings, we need to initiate them on renal protective or the cardioprotective agents in the management of diabetes as well. So apart from these, we know that antagonizing these effects is not only important, and optimal management with escalation of the other molecules which have no benefit on the other systems of the body also may be required if his blood sugars are not brought under control with the basic agents like DPP4 or the SGLT2 inhibitors. So we may use sulfonylureas or the thiazolidinediones or the pioglitazone. So whatever the molecules are available, depending on the management of his sugars, we need to take advice. And depending on the lipid profile of the patient, we need to assess the CVD scoring. And depending on that, we can advise the patient on antiplatelets or lipid lowering medications, and depending on this tolerable levels, we may add other molecules as well, like the newer PCSK9 inhibitors or the estimide, depending on the how significantly we can lower the LDL levels. So this is the holistic approach of the patient with diabetes. So overall, we can see that the diabetes, the most important and most uh, highly comorbid and leaving the patient very much dependent is the CKD. So once a patient, if it is landed in CKD, then it's like more problematic for the patient to manage his blood sugars because of the fluctuations, and he may land up in severe hyperglycemia versus hypoglycemia as well. So depending on that, so always like the prevention and the progression, halting the progression of CKD is very important for a diabetic patient. Thank you.
Thank you, Dr. Akhila. It was a very detailed discussion on CKD and diabetes. We have a few questions for you. Like you said, that diagnosing CKD is of paramount importance. So, what are the early signs and symptoms of CKD in individuals with diabetes? How can we recognize it early?
So one earliest probably will be like biochemical parameters which we can diagnose. So monitoring a patient with diabetes at least like yearly once with a screening test, albumin creatinine ratio is probably the earliest monitor or the earliest biomarker which we can use to diagnose a patient with microalbuminuria stage, which is the early stage, and it is like the reversible stage of kidney disease or kidney damage, which we can diagnose at early. And coming to the symptoms wise, I think once a patient lands up in symptoms, it may not be appropriate stage to diagnose diabetes, where it might be reversible or it may not be reversible. Yeah, so one symptom is like the patient long duration of diabetes coming and landing up in hypoglycemia or presenting with hypos. With almost the same routine without any recent change in the medications, we can assess that it might be because of the creatinine clearance has dropped down, so that the molecules have been accumulating in the body, landing up in hypoglycemia. So the earliest symptom is normal patient landing up in hypoglycemia without any other risk factors or any other comorbidities. One can suspect a decrease in the creatinine clearance, and the other like particularly non-specific for kidney disease, but we can by pedal edema. It can be because of albuminuria or decrease in the renal function, or vague symptoms like decrease in the appetite. So very poor follow-up, patients landing up in visual disturbances, like retinopathy, or landing up in high blood pressure, which can be because of the renal damage.
Thank you. What is the importance of early aggressive management of diabetes in slowing down the progression of CKD, or how does it impact development of CKD per se in a diabetic patient?
Yeah. So always like we have so many trials showing that the microvascular complications are always related to the control of the diabetes, irrespective of the macrovascular events mostly. So these microvascular complications are like 90% always related to how well the patient managed in his previous life the blood sugars. So always like so prevention is all dependent on how well he manages his diabetes based on his lifestyle management or the medications, how well he is maintaining his compliance with the medications. So to the present scenario, we have lot many drugs in our hand to counteract all these side effects, even though the patient is liberal in his compliance with the medications or his lifestyle management, all because of the multiple issues, because of even time constraints in some officials. So we have like the SGLT2 molecules, like we can say that they are really wonder molecules which we can use like as prophylactically also in very high risk patients. For example, if the duration of diabetes is like more than 10 years or 5 years previously uncontrolled, the probability of landing in hyperfiltration stage is very much high in these patients. So we may use this combination, and early initiation of this combination molecules might help in preventing the complications of diabetes.
Thank you. So you did talk about screening tests. Just for our audience, how frequently do we need to check for microalbumin in type 2 diabetes, and when should we start these tests in patients with type 1 diabetes?
So screening for the complications of diabetes. So in type 1 diabetes, actually we can start it is like 5 years usually if it is like before puberty, or 2 years of duration of type 1 diabetes if they are nearing to the puberty or at the pubertal stage. We need to screen them with the test for renal function, that is albumin creatinine ratio, which is a early biomarker. And one other microvascular complication is the retinopathy. So we have to screen these two in patients with type 1 diabetes. And in type 2 diabetes, so actually type 2 diabetes, it goes unrecognized. We don't know even after the onset of diabetes also how long it has been prior to diagnosis in the patient. So it's not like a criteria like 5 years. We may not be like guiding them. Or type 2 diabetes, we can screen them as early as the patient is diagnosed with type 2 diabetes, with the retinopathy or albumin creatinine ratio at the time of diagnosis, and later on at least yearly once or 2 years once if negative findings are there, yearly ones. If they reveal albuminuria or retinopathy changes, NPDR changes, then accordingly 6 months once to to see how the progression of the findings are there.
Thank you again. So you talked about inflammatory pathways. How do inflammatory pathways contribute to progression of diabetes and CKD? And are there any targeted therapies that can help us in this situation?
Diabetes is considered a chronic inflammatory stage. It's considered as an inflammatory state in the body. So many tumor necrosis factor, so many like TNF beta and FGF23. Many molecules have been like the biomarkers have been studied in the glomerular damage in the diabetes, like considering the CKD. So these biomarkers have been studied and they're correlating with the intensity of the damage in the kidney disease. So the antagonists have been tried in the reducing the progression of the kidney damage as well as molecules, novel molecules. They are not into the over treatment of diabetes or in the management of diabetes as such. The side effect profile is more than the benefit associated with these molecules. So not into the practice, these novel molecules did not yet make their turn in the management of diabetes yet.
Coming to management, my first question, one of the most frequently asked question is metformin and CKD. Many of our friends
Yeah.
have a misconception that it is metformin that causes CKD and it should be stopped immediately once the EGFR is below 60. Your thoughts on that? What should be done with metformin? Can we continue? Do we need to stop it? So what are the current guidelines on metformin?
So metformin actually, it's not directly related to the metformin is not actually causing the damage to the kidney, but when it comes to the creatinine clearance and the metformin association already in a patient with diabetes, the risk of acidosis is the guidelines will be formulated based on the risk of acidosis. So the reduction of the dosage of metformin is suggested to treat a patient with diabetes with CKD. So if it is creatinine clearance less than 60, reduce the dose of metformin to half, like 1000 mg. Maximum dose per day, and usually avoid if it is less than 25 creatinine clearance. But based on the clinical profile, actually in clinical practice, absolute stopping of metformin is not at all indicated. So in some cases with CKD, we find severe insulin resistance, and some profile of the patient CKD, we find very low blood sugars, completely remission of diabetes is also seen in some of the CKD patients with diabetes. So in patients with severe insulin resistance in CKD, probably metformin is going to help in those patients. And whereas those patients with severe hypoglycemic of diabetes, probably there we might think of stopping this metformin molecule.
You're right. So it is suggested that less than 30 you should stop because of increased risk of
Yeah.
lactic acidosis. Between 30 to 45, it is suggested you can continue whatever the dose patient is taking, but do check creatinine clearance every 4 to 6 weeks. Above 45, you can continue up till maximum dose. And you can check creatinine clearance every 12 weeks or so. We have been using SGLT2 inhibitors, and you talked in detail about combination of SGLT2 inhibitors and how they prevent progression of CKD. Just a revision for our viewers, how SGLT2 inhibitors are important, and with the availability of data with the dapagliflozin and empagliflozin, what are your preferred agents in this regard?
So yeah, dapagliflozin. So we have seen some of the adverse events which have noted in these trials. So empagliflozin, yeah, the one of the complications we have seen in the trials is like the peripheral vascular disease. So we have noted those one of that might be association, or it might be a direct association, because we have not seen that as a class finding in the other studies. One is that drawback with the empagliflozin, and one is like the cost effectiveness in the present scenario. So one is that coming to the dapagliflozin. So as of now, like almost it has been like 6 months to an year, which we have been using dapagliflozin very much frequently than empagliflozin in our clinical practice. So apart from the side effect profile, like most common complications or the side effects or adverse events is the urinary tract infections. Most of the time, I have seen like in the female patients more prone for these infections, and like poor hygiene in the lower socioeconomic status kind of peoples. And one more finding I have observed with these molecules is like initiating them without like in the stage of hyperglycemia. At the stage of hyperglycemia, if we are using them, they are more landing up in complications with this urinary tract infections. But beforehand, if we reduce the blood sugars, make them euglycemic, and then give the benefits of this by titration of the molecules, probably the incidence of this urinary tract infections are lower, as I observed in my clinical practice. So that we can just observe, take the advantage of this molecules like more into the patients.
Thank you, Dr. Akila. Uh, Another common myth is protein restriction and CKD. Your views on protein restriction or proteins and a patient with CKD, because I believe that is one of the most common situations where we see patients stop taking proteins absolutely. So we Indians are already on a protein deficient diet, and with the development of CKD in a diabetic patient, they stop it absolutely. Your thoughts on that?
Yeah, protein restriction as such, trials also there is, it has not shown any like the benefits of protein restriction in diabetes, and thereby it has been lowered actually. Like the protein intake has been increased. The guidelines have changed to improve the protein intake even in diabetes patients with the CKD, but only the stage like where there is like macroalbuminuria, where the excretion is like more than 300 and ranging into some thousands of milligrams per gram of creatinine. Then at that point of time, probably if the patient is landing up in pedal edema without any like volume excess kind of state, just because of soft pitting type of edema, where it is like clinically more going into hypoproteinemia rather than hypervolemic status. So probably in those stages, we may help them even by more increasing the protein intake rather than decreasing the protein intake in these individuals.
Absolutely right, Dr. Akila, and this is what we have been doing in our OPD. I believe I'm always asking my patients to increase their protein intake, because if we
Yeah.
calculate, especially in North India, where I practice, more than 90% of my patients are vegetarians, pure vegetarians, and
Yeah.
they don't eat egg or anything, and their only protein source is one katori of dal that they eat every night, and they stop taking it immediately. Even if their creatinine rises from 1.2 to 1.3, they'll stop taking it.
Yeah.
And I'm
Yeah.
always pushing them that you need to increase your protein intake rather than reducing it. So this is what we see commonly in our. Just another question: many of our patients are taking molecules like alpha keto analogs, and there is also a newer molecule. I believe if we are talking about CKD and diabetes, we need to talk about finerenone also. Your
Yeah.
experience with finerenone and these alpha keto analogs and cysteine and all of those stuff.
Directly, personally, I didn't yet start any patient with that molecule, sir, but have come across like one or two patients on those molecules, but no follow up, so I cannot comment like in the clinical practice.
So yeah, mineralocorticoid receptor antagonists like Finron we have been using now, and it is especially useful if you're in early part of the disease when your patient is having proteinuria. So I distinctly remember 3 or 4 of my patients where we were able to reverse that. So these patients were already on on ARBs, and their blood pressures were controlled, and we were able to reverse proteinuria in these situations. So as far as MRAs like finerenone is considered, it is a good drug, because now it is not associated with the sexual side effects or the hormonal side effects that were associated with aldactone. So it is a good drug, but yeah, my experience with other drugs like alpha ketone or cysteine, my experience is also very little. So I did search the literature once for my talk, and the literature was equivocal. We still
Yeah.
need to
Yeah.
individualize in our
Yeah.
patients. So thank you, Dr. Akhila, for a wonderful talk, and we had a wonderful discussion. I believe this will help our viewers also. Any last
Yes.
thought or any last concluding remarks for our viewers?
So, yeah, always like treatment of diabetes, always like think about the comprehensive management of diabetes. So, that is the most usually every person gets successful in the treatment of diabetes if we see the person holistically, his lifestyle, occupation, what are his constraints, whether he was able to follow our dietary guidelines or not. So, based on his occupation and all, we have to give the medications according to his, because he's not going to change his occupation for the case just because he has to take the medications. So I think the convertible medications, and we have to take the regimen which is appropriate for the patient. So always I give always the approach is from the patient side, not from the doctor's side. That is the best approach I feel to treat a patient and to increase the compliance from their side.
Thank you, Dr. Akhila. Like Dr. Akhila was saying, it's a good strategy to screen early for CKD, to manage aggressively and early diabetes, to manage diabetes with newer agents like SGLT2 inhibitors and DPP4 inhibitors, which help in preventing and helps in reducing the progression of CKD in patients with diabetes, and again using newer molecules like MRA and ARBs along with newer anti-diabetic drugs holistically improves the complication rates in our patients with diabetes. Thank you again, Dr. Akhila. It was wonderful having you here in this webinar. Now I'll hand over the